Welcome to the keynote lecture. Please, as we have an American guest speaker, we will keep this whole session in the language of English. So if you cannot understand American English, please go to the booth back there and pick up one of the headsets so you get a translation into German. So all English for the next 1.5 hours. I have two great speakers to announce. The first speaker is Dr. Felipe Teran from Pennsylvania, the University of Pennsylvania in Philadelphia, right? Or are you
Correct. Yeah, Philadelphia.
He's done a lot of work on CPR, and you have to know that we in Graz, as everybody else in the world, thinks we have invented CPR. We have Professor Prause here, the sponsor of this great meeting, who's done fundamental work on blood gases and CPR. So we think we're doing this very, very, very well. And yet, I looked at your blog this morning and found out that you're going to be telling us now that we've been doing it wrong so far. So I'm very curious about the next lecture. Thank you very much.
Thank you very much. Welcome. Thank you very much, Simon, and everyone in the organizing committee for having me. It's an honor to be here. I'm Felipe Teran. I'm an emergency physician. I work in emergency medicine at University of Pennsylvania in the United States. I have a special interest in cardiac arrest resuscitation, and particularly in the incorporation of ultrasound in cardiac arrest. For the past 3 years, I've been very fortunate to work in two extraordinary teams that have, first in New York and later in Philadelphia, that have incorporated the use of TE, that is transesophageal echocardiography, during routine care of cardiac arrest patients. This unique experience has given me and my team a really new change and a new perspective in cardiac arrest. Has specifically changed the way we understand cardiac arrest, and has changed and challenged some of the paradigms of cardiac arrest resuscitation. It has basically made us also aware of how little we still know about how to best treat these patients. It has taken us back to the fundamentals of CPR. So today, I want to take you on a little journey to re-examine CPR, to rethink what we know, what we don't know, and to talk about a tool that I firmly believe can change and improve the care that we deliver to our cardiac arrest patients. I have a couple of disclosures to make. I've worked with a couple of these firms doing consulting work, and I've recently also received a grant to fund research that we're going to do in the animal lab with Dr. Norm Hardy's in a pseudo-PA model of cardiac arrest that was funded. It's been funded by the Zoll Foundation. I'd like also to acknowledge and start by acknowledging these individuals that have basically produced and advanced the knowledge in the field. The resuscitation scientists that you see here have described many of the concepts that I will describe today and produce the evidence. Chest compressions are, as you know, a fundamental component of cardiopulmonary resuscitation and a key component of the so-called chain of survival. One of the most important conclusions that we can draw back from the last couple of decades of resuscitation research is that high-quality CPR is the single most important predictor of survival and good neurological outcomes in cardiac arrest. We need to start early CPR. We need to do it hard and fast, and we need to minimize the interruptions. And this therapy hasn't really changed much. Since that original description 60 years ago. In this picture, you can see Dr. Kovenhoven here receiving cardiac massage by his friend and colleague, Dr. Knickerbocker, and a young James Yude on the left side, who were all together working on the development of an external defibrillator. At the time, Knickerbocker and Kovenhoven were doing experiments in dogs and realized that before they even discharged the defibrillator, they noticed that there was a raise in the blood pressure by the simple effect of their hands pressing on the electrodes on the chest. That simple observation led to the description of this closed chest CPR model that we know and practice until this day. And since that important observation, until now, 58 years later, not much has really changed in the way we do and perform CPR. So how does CPR work? According to that original description in 1960, it is the direct compression of the left ventricle between the sternum and the spine that ejects blood out of the left ventricle. This model was described at the time and has been known since then as the cardiac pump theory. This is an example of an intra-arrest TE demonstrating this model. We have a closed mitral valve on the left side of the screen, and that remains closed during compression, and we can't see it very well, but at the center is the aorta that it's been opened during compressions. That is what happens every time we compress, and that's the cardiac model that was described originally. In 2018, we know that CPR physiology involves more than simply compressing the chest. Specifically, we have learned that there are at least two components in the process of CPR that have both specific and very important effects. In this diagram here from a recent review by Harris, we can see the hemodynamic effects of CPR in each one of these two phases, compression and decompression. During compression phase, we generate organ perfusion pressure. Basically, if you can think about that as your systolic blood pressure. During the decompression phase, we're essentially generating myocardial perfusion. And you can think about that as the diastolic blood pressure. That is effectively when the heart gets perfused, and we know that that is the most important determinant of achieving ROSC. But why is it so important from a hemodynamic standpoint? The reason is, doing CPR, even if you are an Austrian that performs high-quality CPR every single time, at your best, you're delivering only 20 to 30% of normal cardiac output values. It is for this reason that we can't really afford to have any performance gaps in doing our cardiopulmonary resuscitation. In order to give our patients a chance, we must ensure that we're effective at this therapy. Let's take a closer look at CPR physiology. During compression phase, we essentially generate a sudden increase in the intrathoracic pressure. That leads to an increase in the aortic pressure that is responsible, for the most part, for our systemic flow. At the same time, increases the cerebral perfusion pressure. That is one of the variables involved in the generation of cerebral flow. During the decompression phase, we have the main mechanism involved is chest recoil. It's basically the re-expansion of the chest wall that generates a sudden drop in the intrathoracic pressure. It is that intrathoracic pressure drop that actually leads to venous return and sucks back all that pool of blood into the right heart, and that is responsible for myocardial perfusion during the decompression phase. There's a few problems with this description of conventional CPR. It's not a perfect model. First, during compression phase, we not only produce an increase in the aortic pressures and the cerebral perfusion pressures, but we also generate an increase in the right atrial pressures. That translates into higher intracranial pressures, or ICPs. And that impacts our cerebral flow. So ultimately, our ability to perfuse the brain during arrest depends on the balance between our cerebral perfusion pressures and our intracranial pressures. Second, during decompression phase, we know that after 10, 20 minutes of continuous CPR, we really alter the architecture, the structure of the chest wall, and we fracture some ribs. That leads to an alteration, a problem with the chest recoil effect. It's no longer good. That has as a consequence that we no longer can generate that effective drop in the intrathoracic pressure, and therefore we affect our preload, our RV preload. That, at the same time, affects myocardial perfusion and affects systemic flow. So can we somehow enhance our CPR? We know that myocardial flow and its surrogate coronary perfusion pressures are the most important determinants of achieving ROSC. Since we know that conventional CPR is highly inefficient, Can we somehow enhance with interventions our quality of CPR? This has been the question that many researchers around the world have been trying to answer over the past 2 decades. I want to mention a couple of devices and one strategy that is still in the early phases of development. The first is active compression decompression device. And it all starts with this. This is how the story goes. Following dinner, a patient in the United States fell down, became unresponsive. The son realized that he wasn't breathing and started to give mouth-to-mouth ventilation. Didn't work, so he remembered that 6 months prior, his mother had resuscitated this gentleman successfully using a plunger. So he ran upstairs, grabbed a plunger from the toilet, comes down and starts plunging at his father. He did that for 10 minutes. By the time EMS arrived, the patient was breathing. He arrived to the hospital and recovered quickly. According to a letter to the editor written at the time by Dr. Lurie and his colleagues at that time at University of California, San Francisco, they speculated that not only did the plunger provide a precordial thump effect on this patient, but and provided effective chest compression, but also there was a significant negative pressure effect from it that they believed at the time was responsible for providing some ventilation to this patient. The patient recovered, and his son, who was feeling pretty good about having resuscitated his father using a plunger, went to the CCU to meet all the doctors and said, I think you should all get toilet plungers for all the rooms in the CCU so that they're available if this happens again. They had to agree with him. So they went to the lab, and over 5-6 years later, they developed the active compression decompression device, ACD CPR. This index case basically led to the development of this technology that in a series of small studies demonstrated that could increase coronary perfusion pressures and in some cases lead to better survival rates. I don't have the time to cover all the literature, but I want to mention that the second device that they developed that was related to this technology, also at University of Minnesota at the time, is the impedance threshold device, an ITD. This is essentially a pressure-sensitive valve that is attached to the endotracheal tube or any advanced airway and basically limits the negative intrathoracic pressure, limits the air coming into the lungs during the decompression phase. As a result, that enhances the negative intrathoracic pressure that we create during chest recoil. It's basically trying to enhance that natural decompression phase, thereby improves venous return and cardiac output. At least 3 randomized controlled trials assessed the use of these devices as an adjunct to conventional CPR. In light of that evidence, the current guidelines say that these devices are not recommended as routine use. However, they say that these devices can be used or reasonable as an adjunct in settings where the equipment is available and the personnel is trained. Many centers that are leading sort of the cutting edge of cardiac resuscitation, at least in the United States, are incorporating these devices as part of their algorithm when they can generate appropriate coronary perfusion pressures at the beginning of the resuscitation. Another interesting concept that is more novel and perhaps much earlier in the development and the stage of research is the concept of head-up CPR. And there's another interesting story to explain how this came about. See, in Korea, there are apartments that are really, really small, actually so small that can only fit 1 person at a time. These buildings have small elevators that don't really fit a stretcher. Therefore, when EMS comes in and they need to retrieve a cardiac arrest patient, they need to choose either take the elevator and put the patient head up or head down, or take the stairs. So a Korean professor from pre-hospital medicine came to visit Dr. Lurie at University of Minnesota and asked him if he had to choose which way would he recommend retrieving these cardiac arrest patients. Dr. Lurie ventured to say that head up would probably be the best for circulation, but he really didn't have any data to prove that. So as a good researcher he went to the lab and started working on the first experiments that later confirmed the clear hemodynamic benefit of resuscitating head up. Using a special tilt table, they randomized swine to receive CPR at different angles of inclination from head down to head up. And they demonstrated that when animals had their head at 30 degrees, they had significantly lower intracranial pressures, and that this also corresponded with better cerebral perfusion pressures. The animals that were resuscitated at more than 30 degrees head up, they also had higher coronary perfusion pressures. This is, as I told you before, this main surrogate of myocardial perfusion and the main determinant of the TV and ROSC. They also showed that when they reach this 30-degree angle, this pressure, the coronary perfusion pressures reach a plateau. And therefore, they concluded that ideal angle inclination of the head was roughly 30 degrees. So, summarizing what we covered, I told you that CPR really hasn't changed much over the past 60 years. I told you that in 2018, we know that there's at least two important phases that explain CPR physiology. Those are compression and decompression. Those are critical to achieve good resuscitation outcomes. I mentioned that the coronary perfusion pressure is the main determinant of resuscitation success and ability to get ROSC. And I described two of the devices that have been developed to try to enhance that conventional CPR. Finally, I mentioned the novel concept of head-up CPR. But most of these studies and the concepts that we have used to explain CPR so far are really extremely general. Still, there's many questions that remain unanswered. See, when we create compression, we increase the intrathoracic pressures, and we somehow generate systemic flow and cerebral flow. But what is actually happening inside the heart? What explains that forward flow? How does forward flow in CPR actually occur? And is the same mechanism in all patients? Well, this tool has helped us answering some of these questions. Transesophageal echo, or TE, has been used to study cardiac arrest hemodynamics since the early 90s. A handful of studies performed in that decade provided what we know now as the information that explains hemodynamics in cardiac arrest. Almost 2 decades after those studies, our institution, along with a number of other centers in the United States, have implemented the routine use of transesophageal echo during cardiac arrest resuscitation. Because its unique location behind the heart, T is not really affected by common limitations of transthoracic echoes such as obesity, lung pathology, mechanical ventilation, and most importantly, it can be efficiently done without affecting the rest of the interventions such as CPR. So using a focused protocol that involves only a handful of views, we can assess cardiac chambers, we can assess the valves, we can assess the great vessels, and assess for response to our therapies during cardiac arrest, and for dynamic changes that occur throughout the resuscitation. In this view, for instance, the ultrasound beam is parallel to the anteroposterior plane in which we're providing compressions. Therefore, it allows us to assess the quantity of that compressions, the effectiveness, and the area of maximal compression. Where is that LV compressed, if it's being compressed at all? There's an example of that during ongoing CPR in a 4-chamber view of TE. It's an example of a rhythm check done with TE. Usually takes only 3 to 4 seconds, and we can restart because it provides high-quality information and high-quality images immediately available. We don't have to struggle, as we do with transthoracic, obtaining those views during rhythm checks. There's an example of all 3 different views obtained in the same patient during the first 30 to 45 seconds of resuscitation, providing comprehensive information that can help us with decision-making basically within the first 2 minutes before even the first rhythm check. The first study that looked at this was in 1993 by Dr. Rita Riedberg in the United States, and they basically used transesophageal echo in cardiac arrest patients to look at what the valves were doing. They wanted to know what was happening during the compression phase. They had roughly 20 patients, and they observed that during compression phase, the mitral valve remained closed, and that during decompression phase in older patients, the mitral valve was open. They also saw that the aortic valve was open during that compression phase. That was all consistent with the described cardiac pump model. In this model, as a reminder, the mitral valve remains closed during the compression phase, and therefore there's forward flow through the aorta, and there's retrograde flow into the pulmonary veins. This is an example of one of our patients demonstrating that concept. The mitral valve is closed, compressions are happening, and you can see how the aortic valve gets open to expel, to eject blood during each compression. This is another example of the cardiac pump model in one of our patients. You can see in a different view now. This is the aortic root. You can see how during compressions over the left ventricle, the aortic valve remains open, allowing blood to actually be ejected. But subsequent studies actually conducted in the late 90s challenged that concept of cardiac pump theory being the predominant mechanism in CPR. They demonstrated that there was a second model that actually accounted for that forward flow, and that model was the thoracic pump. In these studies, they proposed that there were a significant number of patients where it was a thoracic pump model that explained the forward flow, and that was happening by having a mitral valve that was open during the compression phase, and therefore the left ventricle and the heart was basically acting as a conduct, merely acting as a conduct, and the effect of the thoracic pressure changes is what was actually leading to forward flow. This is an example of that happening in one of our patients. This is the mitral valve. You see that leaflet there? The leaflet is completely open during the compression phase. That is how the thoracic model looks like. The mitral valve is open during the compression phase, and the blood can basically go through it in that phase as well. In line with those findings, and providing some additional insight to these mechanisms, Liu et al. Reported that, actually a lot more recently, that both models were actually seen in their cohort of, again, nearly 20 patients. In some of those patients, though, they also realized that there was dynamic change from the cardiac pump model to the thoracic pump model on the same patient. These are images that you can, from this original publication, that you can see what the situation of the valves is at 40 and 80 minutes. In the images on the top, you see the compression phase on the left, the mitral valve is closed, and decompression phase, the mitral valve is open. At 80 minutes, the mitral valve is open during the compression phase, and that is essentially the thoracic model. So the same patient went from a cardiac pump to a thoracic model throughout within their length of resuscitation. So they, for the first time, described that there was some dynamic changes in some of their patients in that small cohort that demonstrated that there was some dynamic progress within these two models. To challenge things even further, a third model has actually been proposed. Using color Doppler, this team assessed the direction of the flow in the pulmonary veins, and they identify what is potentially a third mechanism. This model has been referred as the left atrium pump model and came from the finding that the pulmonary vein had retrograde flows in some patients while the mitral valve was open. Therefore, in these cases, their theory was that the left atrium was actually acting as the main pump, generating flow in both directions. To contrast this with the thoracic pump model, in the thoracic pump model, we have forward flow in the through the pulmonary veins, and in the left atrium model, we have retrograde flow in that valve. Based on that, they propose a new algorithm. Basically, in cases where they saw that the mitral valve was open, They looked at pulmonary flow. If it was forward, they called that chest pump. If it was going backward, they thought it was left atrium pump. So there's at least 2 and potentially 3 possible models involved in a CPR. But why do we care? Why am I telling you this? Why do I think this is important remotely? What is the clinical application of this? Here's my vision. If we can assess, if we can identify these changes during resuscitation, we can potentially change the way we do CPR in these patients and optimize cardiac output in a way that is tailored to their specific physiology. But that is for the future. That is the science and the work that we're working on today in our research. But there are some practical applications of TE that are actually changing the management of our patients today. This is Dr. Amy Sadin, one of my senior residents, performing TE during one of our cardiac arrest patients. So what are those low-hanging fruit applications in practice-changing points of TE during cardiac arrest today? First, we can identify diagnosis. I told you, put the probe in right after intubation, even before getting to the 2-minute mark when we need to check for a rhythm. Cases like this, seeing clots in transit, clots that are in the context of a pulmonary embolism sometimes. In these 2 clips, you can see the descending aorta demonstrating a false lumen, a flap from a type B dissection. This is the cause of arrest in another case. We can't really assess the aorta effectively with any other means during resuscitation. Fine ventricular fibrillation. This has been well described in literature. It's basically patients where we see in the monitor and we have what we think it's PEA, but then we look at the heart and the heart is fibrillating. And in these patients, when we shock them, they actually come out of BFib. They get ROSC. So it only takes a couple of those cases to make you think, oh, maybe I've missed several fine ventricular fibrillations that I thought were actually PEA. With T now, we can see that. Some mechanical problems. Case of displaced pacemaker lead that perforated the intraventricular septum and likely led to the ventricular fibrillation arrest in this patient. This was quickly recognized with TE. Obstructive shock. Not that long ago, I had this case. Put the probe in, PA arrest, no ROSC in the field. This giant tennis ball in the right atrium causing obstruction. You can see that empty right ventricle. No matter how much CPR you do, this patient is not going to do well. We need to deal with that cause of obstructive shock. It's the same patient. On a bicaval view, we were able to assess the superior vena cava very effectively, and I could see how that thrombus was extending all the way up into the SVC surrounding a catheter this patient had. So that's diagnosis. We can also assess interventions that we made. The same patient that I showed you, we decided to give TPA and activate our team to put the patient on ECMO and potentially take the patient for thrombectomy in the OR. Minutes later, that clot, that tennis ball, was lysed. We were able to assess in real time our intervention and see the effectiveness. I could even look at the pulmonary artery and establish that the pulmonary pressures actually drop and the physiology improved significantly with TPA, so much that when my colleagues from pulmonary interventional pulmonology came down and I was thinking they were going to want to take this patient emergently to the OR, they said, we think the patient is now stable. We eventually got ROSC. The patient was treated with anticoagulation and taken for interventional radiology later. That's the same patient several minutes later with more expanded RV and eventually, again, obtain ROSC. We can optimize the area of maximal compression. This is what I personally think is the most promising application of TE in cardiac arrest. See, the effect of CPR, according to what I told you, the cardiac pump theory is we deliver forward flow by direct compression of that LV. However, there's plenty of evidence that this one-size-fits-all recommendation of compressing at the mid-sternum or internipple line stated in the guidelines doesn't really work for our patients. In fact, in many patients, we're not really compressing the left ventricle, but instead the LVOT or the aortic root. Not only this will cause low systemic flows, but even retrograde coronary flows have been documented. plenty of studies from radiology documenting that the anatomy supports this. So this is an example of a case illustrating this concept. The image shows a mid-esophageal long-axis view of TE. In this image, we can assess the left atrium, the aortic valve right here, and as you can see here, the area of maximal compression in that case was occluding the aortic root in the LVOT. As you can see also, in that case, the aortic valve barely opens throughout the cardiac cycle because of that obstruction. Reflecting that finding, the diastolic blood pressure at that point was only 14, and the end-tidal CO2 was 18, as you can see here. This clip now shows ongoing CPR after having optimized the compression by displacing the Lucas, in that case, the CPR device, towards the apex, away from the base of the heart. As you can see now, the aortic valve is open appropriately, providing forward flow. A few seconds later, after repositioning CPR, our diastolic blood pressure, again, our best surrogate of coronary perfusion pressure, went up to 19, and the end-tidal CO2 is 26 at this point, and within a minute, the diastolic blood pressure had raised to 24, and the end-tidal CO2 was 31. Soon after this, the patient got ROSC. Kenton Anderson, a good friend and ultrasound-trained emergency physician at Stanford University, was thinking about this actually a few years ago, and he published with his team the first pilot study in animal that proved and validated this concept. It was an animal trial. They had swine with ventricular fibrillation, and they, based on those radiologic studies, they wanted to compare compressing the aortic root versus compressing the LV. So they used transthoracic echo to identify that position on the thorax, and they used T as well to confirm that more accurately. Using a thumper piston mechanical type device, they randomized animals to receive either aortic root compressions or left ventricle compressions. Once intubated, the animals had the TE probe inserted, and they confirmed the exact location of the compressions. Then they kept the TE in place throughout the resuscitation. The primary outcome was the coronary perfusion pressure. The secondary outcome was ROSC, because they really didn't expect to find what they found, and those were the hemodynamic parameters that they looked at. And they found that the mean coronary perfusion pressure was significantly higher in the left ventricle group. They also found that the aortic, systolic, and diastolic pressures and the end-tidal CO2 were higher on the LV group during all resuscitation times. Regarding survival, and this was unexpected to them, 9 of the left ventricle group, which accounts for 69%, achieved ROSC and survived to the 60-minute mark, compared to 0 in the aortic root group. Let me put this in perspective. What this potentially means is that all those 30 or 40% patients that we've been doing chest compressions over their aortic root, potentially they were in that category. Potentially they never had a chance to actually get ROSC because we were compressing the wrong structures. Of course, there are many limitations to the study. It was a pilot animal study, including the fact that because it's an animal study, doesn't really allow us to assess any patient-oriented outcomes. But we're working with Kenton right now on an observational perspective human study to further validate that concept in 3 centers in the United States right now. This is an example of that same concept in one of our patients. This is mechanical CPR being performed. The compressions are occluding the LVOT and the aortic root here. As you can see, you can't really see that aortic valve open at any time. This is the same case as the clip before, but now focusing on the left ventricle on a transgastric view. You don't need to understand much about CPR to know that that is really not working. That is ongoing CPR. There's really no pressure changes being generated in that left ventricle. This is another case of CPR with compression of the aortic aortic root. So you can see here again, if you play this frame by frame, there's 0 milliseconds where that aorta is open. So there's no way that we can have forward flow compressing there. This is another case of CPR using a mechanical compression device after having optimized the position, and we have a appropriately opening aortic valve. This is another example of ongoing compressions, again, with mechanical CPR device on the 4-chamber view. This is not the right plane to assess for effectiveness of the compression, but you see how there's squeeze of both ventricles. Ongoing chest compressions, another cardiac arrest. This is a patient with proper compressions where the aortic valve gets open. As you can imagine, you can get fancier and actually try to determine flows and get VTIs and quantify the cardiac output, and we're doing that in some of the cases. But many questions still remain. I'm going to only tell you a few of these questions that I personally want to answer. Pseudo-PA. With TE, we've been able to capture patients that did not have a pulse, but then when we look at their heart on TE, this is what they're doing. So this is not asystole, and it's not true PA. It's what's being called pseudo-PA, and we don't really know how to treat these patients. They're not perfusing, they're not generating a pulse. When we put an A-line, they get a pulse pressure, but we don't know if that pulse pressure is enough. We don't know how to interpret that. Some of us, many centers right now, believe that these patients should receive infusion of pressors as opposed to bolus doses of epinephrine and chest compressions. The rationale for that is that there's data from animals demonstrating that when you have the situation and you decide to do chest compressions, you have 50% chances to hit that ventricle during the diastolic feeling phase. And if you do that, it's essentially like stepping on someone's fingers while hanging from a cliff. So it makes sense, and there's some early data from Dr. Peretti's lab, who I'm working with right now, basically demonstrating that in cases like this, it would make sense to synchronize our CPR to that native cardiac activity. And that would probably be the best way to actually deliver CPR if we think that those patients need CPR at all. Aortic compression. I've seen this several times now. What does this mean? Do you see that descending aorta being compressed, squeeze? It's like intermittent aortic clamping during CPR. This happens a lot. What does that mean? Is there any implication in the post-resuscitation reperfusion injury caused by this? Can we alter that? Should we modify that? Is this a thing? We don't know. Large RV. There's normal RV dilation during cardiac arrest. Many of you have been trained to use echo during cardiac arrest, and you look at the protocols, and most of the protocols say, look for RV dilation during arrest. That could be a sign of PE. What they didn't tell you is that unfortunately there's a fair amount of data demonstrating that normally, naturally, during cardiac arrest, we have an increase in the volume of the RV that does not correspond with the increase of volume of the LV. And that is in the absence of pulmonary embolism. So this is something that we see all the time in the early phase of resuscitation, and that continues if we can't get ROSC. So many patients have an abnormally dilated RV. Look at the bouncing of the septum inward into the left ventricle. That, in this case, was not PE. It got better after getting good perfusion and obtaining ROSC in that patient minutes later. This is another case of immediate post-ROSC. Again, we see that often. And because we can see it more now, because we have a better way to assess this, it's becoming more important for us to know what to do with it. Do we call for thrombectomy? Do we push TPA? We don't know. We need to do more research to establish what is the meaning of this RV dysfunction. So intra-arrest TE has 3 important applications today. It can identify patients' specific hemodynamics during CPR. It can identify reversible pathology. It can help us to optimize the quality of our chest compressions. And for those of you in the audience who are thinking, the one thing I don't like is that you're doing an intervention, an invasive procedure during CPR, and the guidelines say that we should do everything possible to minimize disruption of the resuscitation and interruptions of CPR. This is a clip just to show you how little interruption and interference exists between the performance of TE and the resuscitation. This is the probe hanging from an IV pole during the resuscitation, and that's the screen. After completing the diagnostic scan, I routinely hang the probe and turn the screen to the rest of the team so that the screen of my TE becomes an additional monitor. All my nurses now know exactly what a 4-chamber view in TE is, And when they think that the monitor is indicating a non-perfusing rhythm, the first thing they do is that they look at the TE. And most often than not, they know exactly what's going on. They don't jump to try to get pulses. They look at the heart. So what are some of the lessons that we have learned using TE during cardiac arrest? The first important lesson for me is that the current algorithm we use in resuscitation, following this one-size-fits-all approach, where patients basically receive the same therapy regardless of their underlying physiology or their response to our therapies, this doesn't really work because patients have very different physiology. Second, we need to change this search, this absurd search for a magic bullet. It is not going to happen. We're not going to come up with a magic drug. We need to change the paradigm and stop thinking that we'll find a cure for cardiac arrest in a drug or in a device. Think about other important cases. HIV. In HIV, it wasn't a single drug. All drugs fail by themselves. But when put in a triple therapy, there was a coadjuvant effect that eventually led to the change of the natural history of the disease forever. So it wasn't each drug separate, it was a combination of drugs targeting at different components. And that is what many people in cardiac arrest community think we need. Cardiopulmonary resuscitation is a complex, multifactorial process. We need to start thinking in that dynamic approach. For that reason, I think bundle therapies targeting different components that have synergistic effect are most likely to make that significant difference that we need. And I would like to finish with a quote from an editorial in Resuscitation from a couple of years ago. We no longer can accept a treatment algorithm where all cardiac arrest patients receive the same treatment. A patient-centric, personalized medicine approach is the way of the future. But our patients need resuscitation and now, today. So resuscitation scientists and rescuers alike should be feeling the pressure. Thank you.
Thank you very much, Felipe, for this very inspiring, wonderful talk. Thank you. I would have very, very, very many questions. However, I'm sorry, in the interest of time, I'd like to hand over to Professor Chappell now, and then maybe if we have time at the end of the session, we will have a discussion. We've heard Professor Daniel Chappell from the University of Munich in Northern Austria before. He's one of the experts in fluid therapy and fluid therapy physiology. And as you all may have heard, there's a lot of rumors about hydroxyethyl starch going on these days. And he's got very important information for us how this is going to be in the future. Once we have all technical problems set, we're eager to hear from Professor Chappell.
Okay. Thank you very much. So, yeah. So, fluid resuscitation is a topic I could give you like 5 different talks. There's so much to talk about. And as I've just heard, I'm going to focus on a bit of general fluid physiology, general fluid application, and give you a lot of bit about this new HASTE debate that has come up. In life, there's a lot of do's and don'ts. So this is from my last holiday I spent in Japan, and I can tell you some of the don'ts. I tell you they're the do's, they're really don'ts. And I found this picture on the toilet in Japan, and I was quite surprised about what they tell you to do. I wasn't quite confident with this fishing in the toilet, and the sushi wasn't quite as good as I thought it was before. So anyway, if you come to the do's and don'ts in fluid therapy, look at the standard regime. Fluid is water, you can give crystalloids generally, avoid colloids, they're bad for your patients. And we've just heard it from Felipe. It's a one-size-fits-all magic bullet. You can give crystalloids to any patient in any situation. They're perfect for any kind of fluid losses, wherever, whenever, whoever. That is the view of people who don't like colloids. You can build your own opinion if that is true or not. If you look at trials that only use large amounts of crystalloids, you find, especially after abdominal surgery, major surgery, you find weight increases of between 3 and 6 kilos in these studies. And as you know, we only give drugs and we give fluids. So this is obviously going to be an accumulation of these fluids that you've been given somewhere in the body, which can't be quite good for your patient. And we looked at these trials, and you can see the more fluid you give to your patients, the more weight increase you have after surgery. And this accumulation of fluid is edema in your tissue, in your organs. I'm not quite sure if that's what you really want to generate. Brigitte Brandster was one of the first who looked at the amount of fluid given in relation to the complications that occur after surgery. And you can see that if you give, during colorectal surgery, less than 3.5 liters of fluid, your complication rate is about 1 in 4 patients. Whereas if you give over 5.5 liters, as we know that was common standard a few years ago, you're having every 2 of 3 patients are suffering postoperative complications. And looking at the balance, the fluid balance, if you have a zero balance, you have basically complication rate of about 30%, which nearly doubles if you have a postoperative weight gain of over 2.5 kilos. Factors for the development of acute respiratory distress syndrome, we all know the ventilator parameters, we know the duration of surgery, but quite new, James Bloom found that the amount of fluid you give is an independent risk factor for the development of ARDS after surgery. And Silver looked at patients who needed ICU treatment after surgery in this prospective cohort trial, and they compared patients without an excessive fluid balance and patients with an excessive fluid balance, which was defined as over 2 liters positive fluid balance. You can see they have more post-operative organ dysfunctions, especially the cardiovascular and the respiratory system, which are the 2 organ systems that we anaesthetists are actually responsible for, the lung and the heart and the circulation. These patients had less urine output, despite being overly infused, more infections and longer stay in ICU, and moreover, it was an independent factor for mortality increase. So your patient that comes to you before surgery like this and receives a lot of crystalloids, and you send home like that, is not going to be very happy. I'm not going to distress you or diffuse you with this slide, but you can just see that fluid overload is not just something that is bad for the lungs or bad for your stomach. It's really the entire liver, gastrointestinal system, the renal system, your cardiovascular system, your respiratory system. It has dramatic negative effects. And for many years, we've known that hypovolemia is bad for the organs. It's a hyperperfusion. You have organ damages up to multi-organ failure. But we also know that a hypovolemia is bad for our organs. We overinfuse our lungs and our gut, we will get postoperative complications that can really impair outcome. So our main goal should be to maintain normal volemia in our patients, avoiding these 2 extreme situations as far as possible. The substances we have for that are isotonic crystalloids on the one side. And crystalloids, as you know, they contain water and electrolytes. These are not held back at the vascular barrier. They can freely flow between these compartments into the entire extracellular space you can see here in blue, which is about 15 liters in an average patient, divided up to 80% tissue. So you have 12 liters of fluid in your tissue, and 3 liters in your intravascular space. That's your placer volume circulating through your body and contributing to cardiac preload. So the volume effect of crystalloids is, according to physiology, is 20%. And we measured that using direct blood volume measurements. And we found out they're about 17%, so about 20%, which just confirms physiology. That's what crystalloids do. If you infuse 1 liter of crystalloid, 20% stay in your vessels, 80% are shifted into tissue. Pure physiology. So they're an ideal fluid to replace urine, to replace insensible perspiration, replace fluid, which is water electrolytes. Every patient who doesn't drink needs a crystalloid. You have isooncotic colloids. Now, if you have an intact barrier, and this is going to be important during this talk, and it wasn't the talk before, if it's intact, these colloids are retained at the barrier. They can't pass this barrier, so they stay in your intravascular space with a volume effect of close to 100%. We measured that for starch. We measured it for albumin. It's basically the same. It doesn't matter which colloid you give. If it's isooncotic, it stays in your vessels, which again is just confirming physiology. So colloids have a totally different indication than crystalloids. You should only give them if you have an isolated loss from your intravascular compartment, which mainly is blood loss, or to restore cardiac preload in the face of acute shock. A nice animal trial from Roger looked at that, and it was a hemorrhagic shock model. And what they did is they bled their animals down to a mean arterial pressure of 40, and then resuscitated them with fluid to achieve a similar map to where they started from. Now, comparing a colloid group to a crystalloid group, it took 4 times as long to restore them in the crystalloid group. And the reason for that is quite simple. You needed the 4-fold amount. That is what physiology tells us. So we have to distinguish between fluid on the one hand and volume on the other. I mean, the goal will be the same. You just need much more of this to achieve the same amount as you achieve with the other one. And using crystalloids and colloids is basically what we call goal-directed therapy. It's every patient needs a basal crystalloid rate. They fast for several hours, they have bowel prep or something, they're not allowed to drink. So you have to replace the ongoing fluid losses they have. And if you have intravascular hypovolemia, which is by far the minority of your patients, it doesn't matter what device you use to recognize it, you give a colloid bolus. And if you look at trials that did that, and Brigitte Brandstrup was actually one of the first to do it, her goal was to reduce the amount of fluid giving during surgery. She took her patients in colorectal surgery, multi-center randomized trial, gave crystalloid to everybody, and replaced the blood losses either with a colloid or with a crystalloid. And you can see that she was quite successful. She reduced the total fluid amounts from over 5 liters down to below 3 liters. And that had implications on the overall complication rates, especially the cardiopulmonary complications, which were dramatically reduced. And she had a better wound healing, especially in gut surgery. You can imagine that wound healing is very preferable for a good outcome. More modern trials looking at esophageal Doppler to optimize your stroke volume in a double-blind trial, giving colloid and a crystalloid as a bolus with a dose max of 50 mL per kg. They looked at the stroke volume and the corrected flow time, and you can see a significant improvement if you give a bolus of colloid in comparison to a crystalloid. That's a better volume effect, a better hemodynamic response, a better hemodynamical stabilization, despite giving much less fluid. After 4 hours of surgery, you can see 3 liters in the colloid group, 5 liters in the crystalloid group. Now, there were no outcome differences in this trial, which is always the lead for the crystalloid advocates to say, look, if there's no outcome difference, why should I give colloids? Which is true if there's no outcome differences. But this was a double-blind trial with a cutoff at 50 mL per kg. If you succeeded that, you had to switch to a rescue fluid, which was fresh frozen plasma. Contains albumin, is a colloid. You can see in the colloid group, there was basically no plasma needed, 1 or 2 patients. But in the crystalloid group, they received on average 1.5 liters of plasma. So if you're giving 1.5 liters of plasma to your patients in a crystalloid group, you can't really argue that crystalloids are equally effective as colloids if they're getting 1.5 liters of colloids, at least from my point of view. Recently published in Anesthesiology this year from Alexander Yosten and his group, double-blind randomized trial, they measured stroke volume variation, and again used the basal crystalloid, colloid crystalloid with a max of 33 mL per kg. You can see quite nicely that they needed more fluid in the crystalloid group, more patients reaching the dose limit, needing more fluid from a rescue fluid, having a much larger fluid balance. You can see 2.6 liters difference in the fluid balance. And they still, despite getting more fluid, they needed twice the amount of vasopressors and vasoactive substances as the colloid group. So the crystalloid group is getting more fluid, more vasopressors, more vasoactive substances, but they still don't have a better hemodynamic situation, but a worse one. From our hospital, comparing albumin and starch, for 90 days, looking at the renal function in a prospective trial, radical cystectomy, so actually a high-risk group for kidney diseases. They looked at everything: cystatin C, rifle, creatinine, GFR, NGAL, urine output. There were absolutely no differences in this trial whatsoever. No difference in hemodynamics, bleeding, transfusion. There were no differences. Absolutely identical. It was sponsored by Albumin Company, just so that people don't say it's a prone bias. It's quite interesting. They took high-risk patients because they actually wanted to show that albumin is better. Obviously, it's an albumin-sponsored trial. You can see 38% of patients had a chronic kidney disease before this trial started, which is actually a contraindication for starch. And after the trial, there were still only 18 patients. And albumin slightly increased, but no significant difference. And looking at the rifle, after 3 days and 90 days, you can see not one single patient in the starch group had kidney injury or kidney failure. And there was no difference to the albumin group. Oh, I lost it again. So this is from Rupert Pierce, the optimized trial, where we all hoped that this would give us a final solution on what to do. Because they looked at 700 high-risk patients and in major surgery. And they showed a 4% increase of mortality if you don't use a goal-directed approach with colloids, but it wasn't significant, so they basically showed no difference once again. But they incorporated all their results into a meta-analysis looking at the post-operative complication rates, and you can see all trials using goal-directed therapy with crystalloids and colloids show a clear advantage over patients who just receive any kind of fluid at some time. So if you have an algorithm-based approach and perform an early resuscitation of your patients using crystalloids and colloids, you have the potential to reduce post-operative complications. Now, this is a trial for all the people under you who say, look, we only use crystalloids, we're really cool, it's fine, our outcome is the same. There are no trials that support that. It might be, but there are no trials that support it. This is a trial from Konrad Reinhardt. You'll hear his name more often tonight. He compared 6,000 patients in cardiac surgery, 2,000 crystalloid, 2,000 gelatin, 2,000 starch, and said, look, there was absolutely no difference between the colloids and the pure crystalloid therapy. He looked at the starch group and gave them, it was cardiac surgery, so they got 500 mils in the heart-lung machine as a prime solution. They got 3 different colloids for volume therapy, and then they had a faster hemodynamic stabilization, received less fluid balance, less complications, less organ dysfunctions, less mechanical ventilation. So for one, this is the absolute maximum you can achieve with a colloid. If I give a colloid, this is what I really want to achieve. I bet most patients won't even achieve this, but that is brilliant. A colloid is not a wonder drug. It can stabilize your patient. I don't see how that can be called not more effective. But if you look at this trial, this is a gelatin group. They also received half a liter of starch, and then somehow the authors must have forgotten to give the gelatin. At least I understand why the gelatin group isn't any better than the crystalloid group. But if I look at the crystalloid group, I mean, they said it was a pure crystalloid group. They obviously didn't receive half a liter of starch as a priming solution. That's not possible. But they received 1 liter. And the author said it quite nicely. When we changed to only crystalloid, the CVP prime was changed to 1 liter starch. OK. Looking at their volume therapy, I'm not quite finished. The patients received, average patient, 2 days ICU. Everybody who's been in cardiac surgery knows that 11 liters of crystalloid isn't as much as it sounds. They received 136 mils per kg crystalloids. And the total fluids was 262. Means that was 21 liters, leaving 10 liters that were not crystalloids. Now, I'd like to tell you what they were, but the authors don't report it. So 1 liter was the starch, but the other 9 liters we don't know. It might have been 9 liters of blood products, but it wasn't 9 liters of crystalloid, so most probably it was some kind of colloid they didn't report. So this is not a trial showing us that crystalloids are equally potent as colloids. What does the volume guideline say, published 2 years ago now from the European Journal? They say that based on all data we have in the theatre, starch, gelatin, albumin don't cause renal problems. There are no trials that show any signs of renal issues with these 3 colloids in the perioperative situation. They actually say that the gelatin and the starch are actually considered equally safe as crystalloids in volume resuscitation in the perioperative situation. So where do all these negative starch data come from? And this was triggered 2013. You all heard about the EMA with their new contraindication of sepsis, critically ill and burns patients. It derived from 3 trials, and I'm going to just talk about 2 here because one is basically very similar to VICEP. Fluid resuscitation in septic patients, basically severe sepsis, septic shock. They randomized their patients quite late. This is not really a criticism from my part. These are very, very well thought of trials, and the protocol is really quite good, actually. That's why it's very difficult to really randomize these patients very timely. Over 80% were stabilized, obviously, because if they're randomized 12 to 24 hours after diagnosis of shock, these patients would have been resuscitated. 60% in the crystalloid group received a liter of starch for resuscitation. They didn't report the other colloids, but we know that especially plasma and albumin were very common in Germany at that time, and still are. And 27% received a colloid during the trial. This is already nearly basically everybody in the crystalloid group. So is this really a colloid versus crystalloid trial? This is what the authors always say. Konrad Reinhardt, starch kills patients, and he argues that there's a 6% mortality increase in the starch group. What he never tells you is the difference between high-dose and low-dose starch. And this high-dose starch with 100 patients basically means this drug was overdosed. This was given in toxic substances. If you're overdosing a drug beyond the recommendations of all pharmaceutical companies and the authorities, you're actually causing problems. That's what happened here. It was an old starch preparation, large molecules, hyper-oncotic. So 40% received overdoses, and 25% received over 180 mils per kg. Doesn't sound much, but if you think it's hyper-oncotic, so it's 20 mLs per kg is the maximal dose, you are receiving this drug over 9 days, every day at the daily maximal amount. Not quite sure if they really all had an indication there. And if you weigh 80 kilos, you're receiving over 14.4 liters, which in the 6% starch we use today, we're talking about 24 liters. We're talking about 48 bottles of starch in one single patient. Now, I don't know if that is really sensible, but to say that a drug, you give 2 or 3 bottles to initially stabilize your patients and then perform the volume therapy with crystalloids, and then you take a trial group, drown them in starch, and say, this drug is really bad. Over 90% of the patients in this trial all received the starch. It's a wrong conclusion from my side. The chest trial, heavily in discussion at the moment, and I'll tell you why. 7,000 patients, multi-center trial, saline-based starch. All the patients basically stabilized because they were very randomized very late. You can say 11 plus minus 165. Some patients were randomized after 7 days lying on ICU. 1/3 of the patients had acute renal failure when they were included in the trial. We asked the authors to leave these out and do a reanalysis. They refused. This is a contraindication for starch. Looking at kidney function, there were 2 findings. One finding was more adverse events, and the other one was more kidney issues, whatever that means. Because if you look at the Rifle criteria, you have a better kidney function in the starch group. But 1% of the patients in the starch group had RRT. Now, unfortunately, we don't know the criteria because there weren't any, so we don't know why they received the RRT. Because they had a better kidney function, it doesn't really make sense. So this is a mixed bag. We don't really know how to interpret it. Unadjusted analysis in the manuscript. In the supplement, they have adjusted data for age, risk factors, medication, all that stuff. And you can see starch is highly significantly better, and there's no difference in RRT. So I don't see why this should be negative for the kidney. I just don't. But the discussions come about this issue. This is the outcomes and adverse events, and the authors actually stated in their original publications that they're going to do all analysis on an ITT basis. ITT just means all patients stay in their group, whatever happens. If you receive the wrong study fluid, no study fluid, go out of the trial, you stay in your group. They looked at patients with adverse events, 180 in the starch group, 95 in the saline group. And underneath the table it said, adverse events in the starch group include patients who received starch before and after randomization. So that means that the patients who were in the saline group and received starch were shifted over. That is these 29 patients who had some kind of adverse event in the saline group but received starch for resuscitation before the trial. So it's not allowed to change your statistical analysis, but if you do it, you've got to take these 508 patients who receive starch with a 29 and a adverse event and shift them over here. And you've got to increase the denominator by 508 and the nominator by 29. What the authors did was they just shifted the 28 patients over, the 29 patients. If you would reverse them and shove them back over into the saline group, there would be no difference. These guys looked at that and wrote to the New England Journal saying, look guys, this is not right. They twist their data and this is manipulation. The New England Journal sent it to John Myburgh, who's the first author, and he said, oh, I'm sorry, they are incorrect, you're right. That was a transcription error. I mean, okay, it's just a New England publication, it's just the trial that's trying to ban a drug. And I'm sorry we did a transcription error. It's not, really, we sincerely regret it, but it's not data manipulation. The New England Journal said, okay, look, the author said, sorry, it's not a breach of protocol, and we consider it closed. That's it. Bam. Bad luck. The BMJ read this and published an article saying, this is absolutely crazy. Why don't they share the data? Who controls data can control the message, because that what they report and that what we see doesn't match. The results are not the same as their interpretations. And they asked, the BMJ actually asked the authors for the original protocol, which is not available anymore. They changed the protocol after the trial was done. They changed the statistical analysis plan after the trial was done. And they refused to give out any documents or any raw data to the BMJ. Surprisingly, 2 days later, very, very coincidence, they published a revised form of this trial. They just changed the table. This is a new one, and I read it very, very carefully, I can tell you. And I'll go through with you. It's like fourth grade mathematics. You take the 3,416 patients, you add on the 508, and in the saline group, you subtract 508. It's quite easy. The authors managed to lose 53 patients in one group and gain 29 patients in the other group. They won't reply what happened. You can add up all the patients. That's very easy. There's 24 patients missing. This is absolutely scandalous. The authors won't say what happened. But the pressure grew, and the pressure grew so much that the author said, okay, look, we will publish a reanalysis of the chest data. The Georgia Institute of Global Health commissioned it and said, we'll have an independent reanalysis of chest. And they published it as a non-peer-reviewed letter to the NAGM. If you look at the authors, 6 of these 8 authors are from the Georgia Institute of Health. And they're actually the same authors that published the chest trial. So this is an independent reanalysis of their own data. Excellent. This is a scandal. Back to what the guidelines say. The guidelines say, if we look at all these sepsis trials, these are conflicting results and the methods are really, they're not so good, and we should do them all over again. I see it totally differently. We have a crystalloid group and a colloid group. There's this initial resuscitation phase in acute shock where they all received colloids, and crystalloids obviously on top as well. And then we have a maintenance phase. This was the real trial. The one group continued to give colloids, and the others received crystalloids. And I think we'll all agree which group was better. That was a bad idea. After initial stabilization, to carry on with colloids, you shouldn't be doing that. That's really bad for your patients. So this was our new standard, actually what we've all been doing all the time, but this is a new standard, resuscitating with colloids and crystalloids, and then basically only giving crystalloids later on. It's just been published. It's only a registry. That's why I'm not going to really go into detail on any results, despite it being preferable for colloids. It was done before all these discussions came up. That's why they couldn't publish it, because everybody said we're not publishing controversial results. They just looked at what happened on German ICUs. They were just interested, what happens, what do we do? Without giving any specifications, they just directly enrolled the patients and looked at all the data. I think it's very interesting to see that even at that time, we're talking about surgical, anesthesiological in ICUs. We're not talking about internal medicine, cardiac, just really post-operative patients. Less than 50% receive a colloid, and at that time in Germany, a very starch-friendly country, less than a third received the starch at all. If they had an indication for a colloid, they received in mean about 700 mils, a bit more at the beginning, a bit less at the end. That's one bag if they had an indication. And they received it basically on day one or day two. After day 3, it was less than 10%. So really only the minor amount of patients. If you look at these 3 trials that I showed you, they start after 24 hours and give everybody in the starch group a colloid. Now, is the difference between here, do they really have an indication for that drug? The only trial looking at the initial resuscitation phase is Crystal from Jalili Annan. It was an open label trial, so the doctors could use their standard colloid they had on the ward, which was 70% starch, 25% gelatin, 6% albumin. It wasn't double-blind, so that's obviously a point that's been criticized, but they were truly hypovolemic, and they needed initial stabilization, initial resuscitation, and this phase was included in this trial. They were randomized directly at arrival in ICU, only an open-label trial, so they just had to open an envelope. Interesting, as they only looked at the initial stabilization, they received much less fluid. Study fluid, 2 liters colloid, 3 liters crystalloid, and basically only the first 48 hours. So you're taking different patients with a different protocol, a different approach, and different resuscitation, so you have different results. You have an improved mortality in the colloid group after 90 days, and you can see that the patients who had the biggest benefit, sepsis only a slight trend towards the colloids, but the patients with other causes of hypovolemic shock had a clear advantage from colloids, and those are the patients who were basically in hemorrhagic shock, bleeding after surgery. The only colloid that could show an advantage, actually, in these patients was starch. This is the only double-blind trial that exists in trauma. The first trial, 109 patients divided into blunt and penetrating trauma. Unfortunately, the blunt trauma group was so big differences between the 2 groups of injury, comparing crystalloids and colloids, that they had to basically leave those patients out of the interpretation, but they reported the results. So we're just talking about penetrating trauma, and they showed that the colloid was efficacious. They had better lactate clearance, they had less fluid, had a better hemodynamical stabilization, and surprisingly, no kidney injury, because these 16% here in the crystalloid wasn't the crystalloid itself, it was a pre-renal hypovolemia. And they had a better acid-base balance, which might be caused by the large amounts of saline infused here. I'm very fond of this Albios trial. It isn't a volume trial, but you can interpret one result very nicely for volume therapy. It's taking patients in severe septic septic shock and using albumin for resuscitation. No difference in survival. But if you look at the patients who had a shock, that's 63 patients when the trial started, and you can see that these patients were actually resuscitated initially. This is what you do. You give colloids, synthetic ones, and albumin for initial resuscitation. And their post-hoc analysis showed quite nicely, if you still had a shock when your trial started, because what they did is they looked to target an albumin plasma level, and they gave a bolus of 300 mils of 20% human albumin when this trial started, irrespective of if they needed it or not. If you had a septic shock at enrollment, you had a clear benefit from the colloid bolus. But if you didn't have a shock anymore, if your shock was already resuscitated, and you received an albumin bolus, you had a clear disadvantage. And this is using physiology again. If you have a patient who is hypovolemic intravascularly and you give a colloid bolus, he is going to benefit. If you give a patient who is in no need of a drug and you give a large bolus of this drug, you're going to have side effects and disadvantages. So we read all this and we were actually all happy and didn't really see what was coming and was going to hit us. And that was in January this year, the EMA recommending that we should suspend hydroxyacyl starch. Again, all the trials that have been published since 2013 have been either not negative or positive. There are no negative trials. Even the EMA says there's been no more negative trials. What's happened? Well, they base their recommendation on 2 drug utilization studies indicating that starch is used or still used in critically ill patients. And I'm not going to go into detail on these DUS trials because it's terribly boring. I can just tell you that we were part of this trial, and we had 8 patients in sepsis that were included, but the question that was asked was the starch infusion timely related to sepsis? So what is timely related? Retrospective trial, we couldn't really see the diagnosis of sepsis. We gave them the starch during surgery, and we knew that during their 4 or 5 days on ICU, they sometime had a diagnosis of a sepsis. That had nothing to do with starch, and we didn't give starch during sepsis because that was a clear contraindication and still is in our hospital. So, the procedure started, it was under evaluation, the PRAC recommendation came out, I've just showed you, and at the PRAC recommendation, there was an independent EMA expert group, eight people, all heads of some university hospitals, and they said that these drug utilization studies are absolutely inadequately designed. The questions are misleading and the clinical important issues are totally neglected, and said we need to look at these trials again and reanalyze the data because it's absolutely ridiculous to look at these trials like that. And by the way, this expert group was called by the EMA themselves. The expert group agreed that there definitely is a place for starch in the authorized indication, which is acute hypovolemia. They recommend to not suspend it, at least until the results of these 2 major trials that the EMA actually initiated in trauma and in surgery with over 2,000 patients. They're ongoing. They should wait till these results come. And they request that the data of CHEST should be made accessible for reanalysis. This is what the independent EMA expert committee that should actually give a recommendation to the rapporteur. The reply of the rapporteur was quite brief. I don't agree. I mean, come on, here are 8 experts, and there's one guy, 32 years old, he's a biologist. I don't agree. That's it. That's it. He said, his solutions are continued to be used in contraindications by doctors who don't understand what contraindication means. And he said, okay, but it's not really their fault because it's too difficult to distinguish people who can actually receive a starch by the doctors. We've got to help these doctors and suspend it. And further measures to minimize these risks, they're going to be inefficient because doctors don't listen to us anyway. CMDH, 15 to 13 was in favor of suspension, 14 to 14 would have been pro-starch, and we would have had no discussion anymore. I must admit, Germany was among the suspendent countries. A lovely letter appeared in Lancet in March 2018, saying that there are absolutely insufficient data on crystalloids, gelatinous dextrans to promote their use as alternate fluid therapy, especially in surgical, obstetrical, and trauma patients, because all the data we have that shows us an advantage for starch, what's going to happen if we take the substance that's superior, take it away? And for many reasons they all name in this article, they strongly believe that the recommendation to suspend starch is not scientifically grounded and potentially hazardous to patients. Interesting to say that these authors are all anaesthetists, nobody from the UK, Australia, or Scandinavia, and they're all members of this independent either ad hoc committee, all with no competing interests. There was obviously a letter from the other side of the, well, what do you call it? From the other side. To the Director General of the WHO, please help us, please, we need to support our patients who are dying because starch is given. If you look at the authors, Bicep author, 6S author, 3 CHEST authors, 7 of these 8 were from Scandinavia, UK, Australia. Obviously devastated that their CHEST data might be published. Now for all the people who say, look, we only give crystalloids and it's fine, we have no side effects whatsoever. This is from the UK. Now the UK in 2013, when the EMA decided not to use starch anymore. They wouldn't forbid it, but they wouldn't distribute it anymore, so nobody uses it. In the 5 years before that, there was in the most, so if everybody doesn't know the yellow card system, that is where you call all side effects, potential side effects of drugs. There was either 0 or 1 negative report on starch, and always about 100 on crystalloids. Now, since they've stopped using starch, it's gone up by 275%. Might be coincidence, might be because now we see all the fluid overload, the edema of the lung and the gut, and the problems that occur. So this is basically what I think they've done with the EMA. And I want to end this talk with an open letter that national societies have written criticizing the EMA procedure, demanding that the EMA does not suspend starch. that they at least wait till the major trials are finished, and they demand the release of the chest raw data. And you can see who has signed this, Austria and Germany. The ones who haven't signed it, UK decided to be neutral, and the ones who were against it are Finland, Denmark, Iceland, Norway, and Sweden, all participants in the 6S trial. And I want to close with a statement, because I think it's quite nice. We, these national societies of anesthesiology in Europe, demand that the EMA pays attention to medical experts and reconsider their completely unfounded decision. It is time to base a decision on clinical facts and scientific data rather than on politics, and questionable data that are hidden and not shared by the investigators despite numerous requests. So my summary is quite easy. I think we need crystalloids and colloids. Each has its own indication, their own contraindications, and most of all, they are drugs. If we give them to the wrong patient at the wrong time in the wrong amount, we will have side effects. We should use them rationally, indication-based and goal-directed, always in a balanced solution if possible. We should avoid hypo and hypervolemia in our patients. Always use crystalloids, and only crystalloids if you're doing a fluid therapy. If you need to do a volume therapy, use it at least in the perioperative situation with colloids. On ICU with an impaired vascular barrier, different volume effects, reduced volume effects for the colloids. I would do a first-line crystalloid, then switch to colloid. My colloid of choice here would be albumin. But in a hemorrhagic shock, I don't see how colloids cannot be first choice and the gold standard. So my take-home message is quite easy. Be smart. Read the answers carefully before you make up your mind what is the right answer. Don't be fooled. If you look at things twice, you might see it looks a bit different than at first sight. So, to give you an easy way of doing it, just give the right fluid and do that in the right amount, whatever that might be. And give it to the right patient, whoever that might be. And just remember, everything that you toss at your patient at one time might hit straightly back at you, and that can hurt. Thank you very much.
Thank you very much, Daniel. Who in this room still trusts evidence-based medicine? And who trusts the EU? Some people were right, I think, in this continent. Any questions to any of the speakers from the audience, please? If not, while you think about questions regarding HES, I will start with a question to Felipe, if he's still here. Felipe, you know these patients when you're doing CPR, and it's a young patient, you have caught him with ventricular fibrillation and so on, and you do everything you should, and the patient is not coming. Is it worth, and do you think, would you recommend to start changing the spots of the chest compressions at this point, by your experience from TE?
Having no way to actually confirm where you are. You mean just
yes,
just by
trying.
I think it would be responsible for me to recommend that based on the current state of evidence. It's been done with or attempted with end-tidal CO2, and it didn't pan out very well. I think a better design study needs to be done to recommend. I don't even think we are in the position right now to recommend doing it with TE. What I said is our experience, and I make clear that it's based on animal data and sort of pilot level data. If you put that in perspective, a lot of the evidence we have in cardiac arrest science in general is actually not that good. The dosing of epinephrine comes from a study from 1908 in beagles, and we still give 1 milligram of epinephrine based on that study. So I would say no, I wouldn't recommend that. That's what I would say.
But it probably won't harm.
You want me to say that? You wanted to recommend it. So of course, I think things need to be interpreted in the appropriate context. And I think in that situation, what I try to put in perspective in the presentation is that, number one, I think with the current strategies, we don't have a very organized sort of approach to move forward when we realize that we're not basically, that our CPR, that our resuscitation is not working. Some centers in the United States have implemented their own algorithms based on the existing literature. For instance, if you're doing CPR with your with mechanical CPR device and is not and you're not getting adequate coronary perfusion pressures or diastolic blood pressures, some people recommend that you should remove it and attempt manual CPR and see if that helps. There's a few centers doing that. Michigan is, for example, they've incorporated into their goal-directed therapy the use of both the active compression decompression device as well as the impedance threshold device as two options within their goal-directed approach.
Thank you.
Would you say, like, it would be amazing to have TEE in the preclinical setting? We have these very simplified probes that are thinner, and you can only do the short axis, and you can do the 4-chamber view, but you could do it on the street, because we know the patients that come they've been resuscitated for half an hour and arrive at the hospital, where your chest compression point is not going to be really outcome decisive. But on the street, you could achieve a major benefit.
Yeah, we've discussed that at other sort of panels, and the one problem, I believe the device that you're referring to is the Imacor, the disposable probes, which the problem they have, they can't generate they don't have a multiplane, they can't generate a long axis view, which is what I showed there, that actually provides a image that is a true interposterior view of the heart, and that actually allows you to assess the cardiac compression. That is the main problem. I think the view that you can generate, maybe transgastric with some flexion would help. I think we still need more data to move forward. Obviously, it makes sense to do it in the pre-hospital. I think it's going to happen soon. Someone's going to do that study. Maybe it'll be hence.
Thank you. Any other questions?
Thank you for your presentation. You just said that you sometimes change the pressure point during CPR because it wasn't effective. Did you go more down the body, or on the left side, on the right side, upstairs? In which direction? Normally, in the average.
So normally has been, in our experience, we're about to submit our case series with 45 cases, is that it's generally towards the apex of the LV, so away from the base of the heart. But that hasn't been the case in every single case where we've repositioned the area of maximal compression. The way I say it, based on, again, our own experience in the available data, is that rather than actually defining a different point, it's going to be a matter of identifying maybe population of patients that will need compressions in slightly different places. So, for instance, patients with dilated cardiomyopathies with displaced PMI, we know that the heart is just not in the direction that it should be, and we see that very clearly when we put the probe in. You don't find the heart in the standard position. You need to rotate your hand a lot to actually go and sort of find the heart. So you know that that apex and that LV is situated in a somewhat sort of there's anatomic variation. I think one of the things that I'm interested in is studying. Obviously, we'll need sort of large multi-center registry kind of level data to do that. Study subsets of population and see if we can identify sort of trends and kind of common points. There's, I think, I don't personally think that TE necessarily is going to be the way of the future. Right now, I think it is unique tool that allows us to assess, as I showed, the anatomy and the physiology, and that can provide us with answers, maybe understand better how this works. Maybe in the future it will be a non-invasive device or technology that will allow, for instance, to assess myocardial perfusion. That would be neat. And maybe actual location of the left ventricle without the need to do TE. So at this point, I think we're early in the kind of early stages of this. I think the way I see it is we're trying to provide theories, and those theories need to be obviously tested with proper studies. As you all know, it's hard to do cardiac arrest research, but I think the appropriate people are kind of following that direction already, both in Europe and the US. So I expect seeing some interesting results on this field in the next couple of years.
Thank you very much, Felipe. I have one last question, or maybe we're allowed a few more minutes, to Daniel. Daniel, with reference to the lectures we had early in the afternoon about trauma coagulation and glycocalyx, should we be carrying HES on our helicopter, and if so, who should we be giving it to?
So this was not to be an advocate for HES. I don't mind what colloid you take. You can take gelatin or you can take albumin, whatever you want. I am a clear advocate of colloids. Yes, I do believe. Again, not every patient. So if we have a trauma patient who's not bleeding, why should I give him a colloid? I'm not going to cause any benefit. I'm going to cause damage. But if I've got a patient you come to the scene and he's lost at least 1 liter of blood, or maybe 1.5 liters, he's hypertensive, you want to prevent organ failure. I mean, you want to prevent a hyperperfusion of the organs, and that you're only going to achieve if you infuse fluid. You can infuse either 3 or 4 liters of crystalloids, which is going to take you ages. You're going to get maybe 1 IV access and not 3 or 4. You're not going to get a large bore down your throat. It just makes sense to give effective amounts of fluid in a short amount of time. And I think we all agree that the fluid therapy is not the number one. Number one is obviously damage control, stop the bleeding, get to hospital, look at the coagulation, and then there's the volume therapy to maintain the perfusion of the organs, to maintain an adequate perfusion pressure of the brain, and that, I think, is the main aspect. We're talking of small amounts of fluid in the preclinical setting. I mean, the Americans hardly give any because they've got a no doctor-based emergency system, and they have the same quality results as we do. So I would say I definitely need it, but not for the majority of patients.
Thank you. Are there any other questions from the audience? A lot.
Obviously, Sweden had to come now.
I'll shut up. No, I have a short question. First of all, congratulations to both of you. Excellent presentations. Felipe, I'm curious. Do we actually know how the sternum is moving when we compress it?
How the sternum is moving?
How the sternum is moving. Is it actually going up and down horizontally, or is it moving like a hinge? Because that is a bit interesting, because if it moves like a hinge, it doesn't matter where we put the pressure, maybe.
I don't know the answer. I haven't looked at data. I know that there are some studies looking at sort of the patterns of deformity of the chest wall with CPR. But I don't know the answer to that. I can tell you that, contrary to one might think, small changes, movements of your hands or the piston actually translate into very different patterns of compression seen on the TE. So you would think that if you're pressing the sternum and then you're pressing lower in the sternum, maybe slightly left, but you're still within the rib cage, you would think that that wouldn't translate into significant changes in the compression pattern. I think that's in part why this wasn't something that we've paid attention to in the past. All the studies that I showed, many of them, the 4 studies, were done in the 90s. And after that, there was basically like a pause. We sort of drop it. It hasn't been until like now that we've sort of regained attention to this. I don't have the answer. I do think it would be interesting. We should do a study, maybe a cadaver study. There's a lot of post-mortem studies in CPR where I think that would serve the purpose.
Thank you very much. One more question in the back, please.
Here.
Thank you. Just one quick question, because you showed on the pictures on the screen that after you change the position of the I think carpals, altarpals or whatever, Lucas, the blood pressure raised about 20 millimeters, whatever. My question is: should we, in a pre-hospital setting, should we, if we have continuous blood pressure monitoring, should we change the position of our hands to see if we can reach a higher blood pressure with the same person? So it's like repositioning.
Yeah, so that's sort of similar to the question that he just asked, and I think based on the data, I guess I can't recommend that from the experience perspective, from the data that we have using TE, or from our personal experience. What I can tell you though is, if you're doing CPR and you're pressing hard and fast, and your coronary perfusion pressures are your diastolic blood pressure, which is your surrogate of your coronary perfusion pressures, are not racing, are not improving, then you shouldn't keep doing the same. So, the definition of insanity is doing the same thing over and over, expecting different results. I think that really applies well to CPR. If you're doing what you think is high quality CPR and it's not impacting your hemodynamics, then you should try something else, and that is maybe switching compressors, maybe switching to a mechanical device, maybe adding a device to try to enhance, take advantage of one of these, the decompression phase part, and for sure, move your hands and see if that makes a difference, or move your device. Again, I think if you have a dead, if you have an unresuscitated patient, there's very little harm you can, cause from there, I think. And if your interventions, your standard interventions, have not worked, you follow the guidelines, and you're still not getting ROSC, I think in that situation I would consider buying time. And in 2018, that is possible with ECMO. You can buy yourself time if you think that the patient should be resuscitated and you still can't get ROSC, and the patient meets the agreed criteria, then ECMO will be a possibility. If you don't have access to that, if you're in a hospital, you don't have access to eCPR, then you should try things like maybe trying different spots. And you should use your untitled CO2 and your arterial blood pressure to try to follow that and see if that actually creates an impact.
One very last question, and then Simon, please.
Oh, it's rather a comment just on the question previously. Thank you very much for both of your presentations. And having tried just once to move the hands sidewise, or this is just anecdotally, yeah, we had a hemothorax as well. So I think we should be carefully advocating just to do it blindly and really re-evaluate what we are doing there, because definitely the mechanics are completely different if you press on the ribs, for example.
I completely agree with that. This is why we need data.
Ladies and gentlemen, Undank ist der Welt den Lohn. If we keep discussing here, other people will eat the buffet. So please, if you want to ask more questions, please come up and chat with the speakers. Otherwise, the session is closed for now. Thank you very much.
Thank you.